in addiction medicine to deal with the symptoms that individuals coming off of opioids typically experience, I very quickly found that that both CBD, cannabidiol, and THC, delta-9 tetrahydrocannabinol, but more specifically 11-hydroxytetrahydrocannabinol, which is the metabolite that is a result of the hepatic first pass effect, or effectively eating cannabis. That those two things were perfect substitutes and even superior in many ways to any of those prescription comfort medicines that I would have prescribed historically.
You know, you said so many very interesting things there, and I think going back to the medical community, the difficulty that we've had over time asking the medical community to embrace this, it's because of all of the things that they've been taught. But I think it's really interesting that a lot of the medical professionals that are advising about addiction have themselves been involved in 12-step programs or other recovery programs that absolutely condemn the use of a psychotropic medicine to help get someone off of addictive drugs. And, you know, as someone who has seen that is clearly not the case, how do you explain this to fellow doctors who are arguing that point?
Well, so the literature is out there, and I mean, what I would say is, first and foremost, I mean, it's a lot easier to make the case for providers who are leaning, based on their own philosophy in the direction of absolutely no, never. It's a lot easier to make that argument for cannabidiol than it is for delta-9 tetrahydrocannabinol, or THC. And so I find that I have the CBD conversation with them first, and I show them the data on CBD, specifically as it relates to pain, specifically as it relates to attenuating opioid cravings, specifically as it relates to managing post-acute withdrawal symptoms, which are often the more problematic period of time for individuals in recovery than even the acute or the subacute phase. So I show them data. I mean, if you're attempting to change a medical professional's mind, the tool of choice is objective data. And so, and believe it or not, that data exists to the tune of hundreds upon hundreds of peer-reviewed medical journals, both in this country and outside of this country.
More like thousands.
And so, armed with the appropriate scientific literature, I have the CBD conversation first. And once I can get these individuals to understand the science behind the use of cannabidiol and my anecdotal firsthand clinical experience, I find that it's a lot easier to have the tetrahydrocannabinol discussion, and that they're already open to the notion of cannabis therapeutics because of the cannabinol, the cannabidiol conversation.
Yeah, I don't know if you've been following the court cases that have been transpiring lately, but I was interviewing a lawyer a couple of weeks back who was representing a gentleman who had been sentenced to 3.5 years in prison for carrying hashish, which he purchased legally in a medical dispensary. He was a card-carrying medical patient. And the judge basically declined his appeal on the basis that cannabis, as defined by the criminal code, is vastly different from cannabis as defined by the medical marijuana law. And so what was really interesting is the fact that he sort of rewrote the definition of what marijuana is and what it means to this law in the state of Arizona, and he denied the appeal and sent the appellant back to jail for another 2.5 years. And
wow.
Yeah. So as a doctor, when it comes to, dealing with these laws, and the other thing too, you mentioned CBD and how it's much easier when you really want to convince someone that there really is no danger in this, to approach it from the CBD side of things is a very good idea. However, the DEA a year and a half ago or so actually gave CBD its own class within Schedule 1. It gave it its own numerical code, I should say, within Schedule 1. And there's been debate all over the industry on the legal side of things as to what that really means. And then the state of California is actually putting restrictions now on CBD in terms of their interpretation of the FDA rules, according to the Farm Act of 2014, despite the fact that hemp was basically legalized in the newest farm bill, which is the Agricultural Improvement Act. So there are all these complex rules and legislation and court judgments that are all conflicting with one another. And if you were to have any one of the policymakers in an office to talk to them face to face, what would you tell them about this?
Well, I would tell them fairly unequivocally, and I've done this. I mean, I've been on camera and have, in no uncertain terms, said, Governor Ducey, I think this represents a window of opportunity for the state of Arizona to take the lead on this, given our opioid epidemic statistics, which I'm very thankful are made publicly accessible through the ADHS website. I said, wouldn't it really be something if the state of Arizona could take it one step further and acknowledge the therapeutic role of cannabis, specifically in the management of opioid use disorder, which, by the way, other states are considering. So this is not a novel concept by any means, by any stretch. However, I think it would speak volumes for state legislators to include opioid use disorder as one of the qualifying conditions on the medical marijuana certification statute. From my perspective, if I had the opportunity to have the ear of one or more state legislators, I would be remiss if I didn't talk about my direct patient experience with individuals, including some of our veterans, by the way, who, as a result of injuries sustained in a career of service to this country, found themselves in a position of being maintained on prescription opioid doses in excess of 300 morphine equivalents, which could easily kill several elephants. These individuals are among the tens of patients. I treated 60, 70 patients that were effectively brought down and off, in many cases, their high-dose prescription opioids because they had access to medical marijuana. And if you ask these patients in their own words to describe how this successful effort was different from any failed historical effort they had previous to this one, they would tell you that the resounding difference, in fact, the only difference between the success that was available to them this time and every other historical pursuit to either reduce or get off of their opioids was access to medical marijuana, period. And these very same patients have volunteered to, take on a greater advocacy role in the state because of the experience that they had that they just weren't able to duplicate historically.
One of the things I find really interesting is that these veterans that are participating. I'm sure you've heard of Sue Sisley, Dr. Sue Sisley, and her study with the veterans. Yeah. I've spoken to a lot of these veterans that are participating in her study, and I know she's actually looking for more veterans to round out the numbers a bit. But most of the veterans that I speak with who are now advocating for the use of cannabis to help them not only with addiction, but also with their struggle with PTSD or post-traumatic stress disorder. And, I find it really interesting that so many of them have said that they were on the brink of suicide before someone suggested that they use cannabis. And since using cannabis, a lot of those suicidal thoughts have diminished to the point where their lives feel a little bit more manageable. And I find that exceedingly interesting. And when you look at the numbers of suicides that are happening around the country, and sadly, so many public figures are also part of this trend of suicide, and then you consider the side effects that are required to be read on air whenever a pharmaceutical company is advertising their product to consumers. They have to list out all of these side effects. And I'm just mesmerized when I listen to a 60-second commercial, and 40 out of those 60 seconds are the side effects. And one of the side effects in most that I see happens to be suicidal thoughts. Yeah. And I mean, as a physician, it must just be boggling your mind as to how a drug can be approved for consumers when death and suicidal thoughts are listed among the mandatory disclosures of side effects. And yet cannabis has very, very few side effects, and none that are fatal, with the exception of someone being so inebriated they can't drive and managing to kill themselves in a car accident. Marijuana hasn't really killed anybody. So it leaves me speechless. What are your thoughts?
Absolutely. And I mean, but this is modern medicine, and I think the public is largely aware of how ridiculous this sounds, because since the advent of pharmaceutical ads on television. But the medical community has known this for a long time, and you're absolutely right to find it asinine that something that's supposed to prevent suicidal ideation can cause it. Unfortunately, this is particularly been the case for psychiatric medicines for a very long time, far longer than the public is aware of, certainly. I would agree with you, and I find it knowing a little bit about access to the like what the veterans are actually accessing with regards to quality of product in the Sue Sisley trial, which is being coordinated between the University of Arizona and Hopkins in Baltimore. It took her over 5 years to even get approval to do this study with our veterans. And once she received approval, they only allowed her to use, my understanding at least, is that they only allowed her to use cannabis from a single monocrop affiliated to a university that had an agricultural program. And that when third-party testing was done on this monocultured crop, the cannabinoid content was inferior to anything that could be grown in a hydroponic, aquaponic, or true non-monocrop, non-GMO setting. And so even with the inferior product, we're getting positive feedback preliminarily from the veterans that have been included in the study, which is the only way that she would be in a position to recruit additional participants in the study. If the overwhelming feedback from the veterans was negative, she would never be allowed to do that. But even with this inferior quality product that represents the only way that the government and the powers that be would allow Dr. Sisley to conduct a study of this nature on our veterans.